Xanthi, please ask the first question.
So, hi, Elise. What drugs do you use to establish your epidural blocks?
Yes, so for the skin, I infiltrate with lignocaine 2%, and then I use normal saline for my loss of resistance to saline technique. For my test and bolus dose, I use 0.2% ropivacaine, and I add 75 to 100 mics of fentanyl. And I put it in a 10 ml syringe up to 12 mils. I give 5 mils for my test dose. I wait 5 to 10 minutes and check that the patient is asymptomatic and do my tests to check that it's not intravascular or intrathecal. And then I give a 7 ml bolus. And then I connect the epidural to an infusion with 0.2% ropivacaine and 200 mics of fentanyl in a 100 ml bag. So essentially I use the same medications for dosing for my test, bolus and infusion.
Sorry, what did you say you use for your test, please, Elise?
I use a high volume but low concentration local. So I use 0.2.
So you said 0.2% Ropi with 75 to 100 mics of fent. Did you say what volume you would use?
So I give 5 mils as my test dose.
Yeah.
And then I wait and check the patient is asymptomatic. And 5 minutes later, and I do my testing, which comes in the next question. And then I give 7 mils as a bolus dose. And then I connect the infusion, which is also 0.2% ropivacaine and 200 mics of fentanyl in a 100 ml bag. And I run it between I started at 6 to 8 mils, between 5 to 12 mils, and with 5 ml boluses every 15 minutes.
So you use a PCEA?
Yes.
Okay. Would you use any other drugs? Have you ever used any other drugs to establish your epidural block?
That's the standard that I am now used to using. When I was first starting to do epidurals, various consultants would use different things. They'd use lignocaine, 1% with adrenaline, 3 mils. So I have used other things before, but this is the approach that I use as a standard.
Sure, that's wonderful. How can you be sure the drugs you inject into your epidural are not going intravenous or intrathecal?
Yep, so partly it's my loss of resistance technique to saline. If I feel like it was quite an easy loss of resistance, and then secondly, it is a little bit trickier with saline to know that it's not intrathecal, but I have had one instance where there was clearly a really rapid gush of fluid coming back. So partly if there's not a rapid gush of CSF coming, clear fluid squirting back at me, I use the meniscus test and check that there's a slow drop. You can also see if there's any blood using the meniscus drop test. I then ask the patient to look out to tell me if she's got symptoms of tingling around the mouth, tinnitus, and that she can move her feet over the next 5 minutes. I also use the loss of resistance syringe to gently aspirate. I don't want to aspirate too forcefully because that can collapse a blood vessel, but I use the loss of resistance syringe, and if there's no blood coming back, I'm happy it's not intravascular, and the other test, I'm happy it's not intrathecal.
Would you use anything in your drug combination to see whether it's intravascular?
I know some people use adrenaline and see if there's a tachycardia. I find that tricky because a woman who's in labour contracting may also have a tachycardia, so I just find that it's not always a reliable way of determining intravascular, so I use my other techniques.
Would you have any other information that will give you that your injectate has been injected intrathecally?
So I think I apart from what I've said, like the clinical symptoms, meniscus test, yeah, I don't. I don't know of motor block. I guess if she had a really clear motor block very quickly, yes, that would be the other test.
Yeah.
So I asked her, sorry, so I did ask her about moving her feet, that she could move her feet and legs. Anything
else that would happen if you put something, 5 ml of 0.2% ropienfant into the so-called intrathecal space?
I spoke about tingling around the lips, tinnitus, some perioral numbness.
Yep.
Yeah. They would be the early signs. I mean, there are other signs of, but I would have thought would be a later signs.
Yeah. So 3 hours later, the midwives inform you that this lady needs to undergo a CAT2 cesarean section for failure to progress. There's no fetal distress. They tell you that she's been using her PCA button frequently, so she's been PCEA.
Mm-hmm.
How do you go about topping up an epidural? This epidural, which the lady has been using the PCA button frequently. So how do you go about topping up this epidural for a cesarean section?
Okay, that's a little bit concerning that she's requiring a lot of boluses. I would want to know that this epidural is really reliable in order to use it for a Caesar. It would, if I did the epidural and I felt that it was an uncomplicated first pass, relatively straightforward epidural, and then it's always been working really well, that is a little bit different to somebody who I've had to go back once or twice, and sometimes we use the magic number of twice as having to troubleshoot an epidural, that maybe it's not that reliable. And so if she's using her boluses quite frequently, that is a little bit concerning. I would be checking at the level of her block and making sure it's that she's got a good block. I would draw up a syringe of 20 mils of 2% lignocaine with adrenaline and 100 mics of fentanyl. And as long as I would give 5 mil, I'd give 1 to 2 boluses of 5 mils, and see if she gets a motor block with that, and see what the block is like. It looks like I'd be a little bit worried about you moving on to a spinal if it looks like this top-up has had minimal effect, because I'd worry about a high block. So if I did these top-ups and it wasn't working, I think I would have a lower threshold. I think I would rather move to a GA Caesar rather than doing a spinal.
Time's up. Thank you for that question. Okay, Neil, please ask the first question.
Okay, Lise, apart from his BMI, what other factors do you consider when deciding to proceed with a general anaesthetic in your small rural hospital?
Well, I think all local hospitals would have some sort of policies or guidelines about our scope of practice. So I would be referring to that when deciding for this patient. And if it wasn't clear with the guidelines, with the policies, I would also be speaking to my GPA colleagues and the hospital executive to help me make that decision. It wouldn't be a decision just purely made on my own. But in principles, the BMI of 38, most, I think, local hospitals of this size would fit within the scope of practice. The type of surgery he's having, it's not particularly a high risk surgery, so that's one factor. I would do a standard preoperative assessment, and hopefully we would do that in a pre-admission clinic. I would look at comorbidities such as ischemic heart disease, severe respiratory COPD, severe ankle spondylosis or rheumatoid arthritis that might affect his airway, severe untreated sleep apnea, uncontrolled type 2 diabetes. I would also then look at his anaesthetic history and see if he's had a past history of a difficult airway. That itself is the biggest concern. If there was a documented history of difficult airway or any anaesthetic complications such as malignant hypothermia or significant desaturation during anaesthetic. I'd finish off the anaesthetic history and in terms of medications, allergies, family history of anaesthetic complications, and smoking, aspiration risk, reflux, and then do an examination of his airway, chest, heart sounds, and look at blood work and ECG, and if there's any extra investigations that were indicated, I would also ask for them before deciding to proceed with the surgery.
Okay. Do you ever consider the factors such as hospital-related, sort of, rather than patient generic factors? Are there any hospital-related issues you might consider?
To decide whether or not this patient can be done.
Is suitable.
Yes.
Yeah.
Yes. Well, certainly, like I said, we're 2 hours away from the next hospital, the bigger hospital, and there's no HDU or ICU, so we would need to be happy that this patient is unlikely or has a low risk of requiring those services. And I think the hospital would have some sort of a local policy. We do have 24-hour surgical cover, so that's helpful. But the main limitation would be the lack of HDU, ICU facilities, and
Okay.
not having theatre like present on site, that they're on call.
He tells you that he's had a GO for a lap collie 3 years ago in Melbourne. How would you assess the patient to predict the ease of hand ventilation and intubation?
Right. So the idea that he's obese is, there's a sort of different level of normalization these days. However, BMI of 38 is technically obese, so that itself is can make hand ventilation and desaturation more likely, and if he does have sleep apnea, that is magnified. I would assess his face shape and see if he's got likely to have a good seal. Presence of a beard is quite concerning. Any dysmorphic features or syndromal features could also make things difficult. In terms of intubation, I would be doing a Mallampati, looking inside his mouth, Mallampati score, assessing how wide he can open his mouth, look at his jaw protrusion, have a look at his teeth, whether or not he's got dentures. That will actually make things easier if I can take them out, and have a look at his thyromento distance. And I'd also be assessing the adipose tissue around his neck, just in case we need to go down a front of neck axis, and also his range of movement of his neck.
Which of those physical factors do you think is the best predictor of a difficult intubation?
I don't think there's any particular one that has a reliable positive prediction value. I think it's a combination of factors. I understand the thyromental distance and receding chin potentially might have more of an influential factor, but in essence, it's not particularly one factor. And certainly the past history of difficult airway, that's probably the most important factor. And
in terms of a beard, if he had a beard, how would you cope with that at the time of
well, I have actually asked a guy in pre-admission clinic this week if he'd consider shaving off his beard. I feel like women at Caesars shave off their pubic area, and he actually kind of refused and said that nobody else had asked him to do it before. So I actually would have that conversation if I felt he was a difficult airway. I personally think it's reasonable to ask that question. And then if he refused to, we'd certainly have an informed discussion about our options and why I'm concerned. My options, if I was to go ahead with this procedure, I've seen the idea of putting Tegaderm to see if we can get a better seal. Some people just give rocuronium and put an LMA in if they're worried about being able to bag mask the patient, or we position the patient well and use a vice grip and get somebody else to hold the bag. So they're all various different strategies.
Okay.
And have good pre-operation.
So let's just quickly, sorry, Neil.
It's just good pre-oxygenation to increase our safe apneic time.
He, given his body habitus, he may have a bit of sleep apnea.
Mm-hmm.
How would you screen for that?
So we use the stop bang screening. So I ask about snoring, tiredness during the day, observed apneas, if he's got a history of high blood pressure, his BMI over 35, and his age and gender. So he already, based on that, is screening positive for suspected sleep apnea.
Okay. He had a GA for the lap collie in Melbourne 3 years earlier. Would you like to get more information there?
Yes, I would like to get the anaesthetic record from the hospital in Melbourne, if I could, ideally, and scan.
Excellent. That's the end of the question. Thank you very much. Okay, Santhi, please start with question 1.
Ellis, so what precautions would you take would you take it routinely if you were to lose an airway while you're gas inducing this child, or generally a pediatric gas induction?
Okay, so just to start off, as a 3-year-old having a tonsillectomy, which is already at the extreme of my scope of practice, and it's a shared airway. So I would routinely check, for this setting, I would ask for a second GPA to routinely be part of this case for me, or if that was not available, have my most experienced pediatric airway nurse. Secondly, I would put EMLA on the kid and consider if it's possible to get an IV access first using distraction techniques and rapport, even if I was to do a pediatric gas induction. However, if I haven't done that and during the induction I've got monitoring on, but I've got loss of airway, it kind of depends on where I am. I would have hopefully liked to have a cannula in at this point, but if I haven't, I would make sure that the patient is deep on 8% SIVO. I would have had my rescue drugs already drawn up, so I would have had succinylcholine. The IV dose would be 2 milligrams per kilo. IM dose is 4 milligrams per kilo. I'd have atropine 20 mics per kilo and some propofol drawn up. And so if I didn't have IV access, but I was worried about laryngospasm, loss of airway, firstly, I would reposition. If the kid's just with SIVO, just had SIVO, they should actually be spontaneously ventilating. So it might just be the positioning of the airway that's caused the obstruction. So firstly, I would do jaw thrust, avoid putting pressure on the soft tissue of the jaw, and make sure that I've got ideal positioning of my bag and mask. However, if I'd done all that and it wasn't working, or there was a true partial complete laryngospasm, I would be trying to get IV access. But if I couldn't get that quickly, I'd be happy to use succinylcholine 4 milligrams IM. I'd also be checking the rest of my monitoring to check the heart rate, make sure that the kid's not bradycardic. If he was bradycardic, I would be using atropine 20 mics per kilo. That can also be given IM, and starting CPR if the fetal heart rate was less than 50. I'd be scanning the rest of the monitor, the end-tidal CO2, the waveform, saturations, heart rate.
Would there be something in your pre-anesthetic questionnaire to the parent about maybe a possibility that you might lose your airway here?
Yes, so if the kid, many kids with tonsils have sleep apnea. So if there's a history of obstructive sleep apnea, that would be more concerning. Also, if the kid on the day had a bad cold, depending on how sick that kid has been as well, I would assess the suitability of even doing the operation on the day. But the sleep apnea is a risk factor for obstructing the airway for tonsils.
Is there any, so did you tell us about sucks being given IM as well? You did mention that.
Yes, 4 milligrams per kilo IM if I had no IV access.
Yep. Is there anything else that you would use in your circuit that would maybe mitigate the situation just before you're losing the airway, or maybe just about, but you can do something to just tide over the situation at all in your...
You can use adjunct, like we could try an oral pharyngeal, nasopharyngeal, and improve our positioning. You could use an LMA in the interim. With the vortex approach, you could use different lifelines. Yeah. And increase your FiO2 to 100%. Yeah.
Anything else in your circuit that you can use at all to help with the situation?
In your circuit, you could do PEEP. If you think you've got laryngospasm, you'd be doing. It depends on what you think the reason is, but yes, PEEP, and have a good seal.
Wonderful.
Elise, You mentioned that you would make sure the child was deep before you manipulate the airway. How would you determine whether the child is deep enough to tolerate manipulation of the airway?
The tone of the child, like if the child is sort of flexing, their arms, the tone on the outside also can reflect the tone in their airway. Yeah. So, and you look at their pupils, if they're forward facing, they would be the tests that I would use. And
anything else, Elise?
Well, they're asleep, they're not responsive, they're not moving. Yeah.
Heart rate.
Oh, yes.
Rate.
Yes. Heart rate, rest rates, or in reflection of being deep. And the SIVO is definitely on 8%.
The problems with laryngospasm are often from going in too early with airway control.
Mm-hmm.
If you did get laryngospasm, how you've mentioned you give intramuscular succinylphonium.
Mm-hmm.
Are there any other drugs that you could use to alleviate the spasm?
If you didn't have IV access, or if you did have IV access?
If you didn't have IV access, you mentioned giving intramuscular sucks. That's one approach you can use. Have you heard of any other approaches you might use? You mentioned using some PEEP. You've mentioned putting the oxygen up, the FiO2 to 100%. Are there any other drugs that can sometimes be used to alleviate the spasm?
Yeah, I'm not aware. Like, I know you can give propofol IV. I'm not really. No, I would be using my measures. I could ask somebody if I didn't know, but I'm not aware of another drug. I mean, atropine you can give IM, but that's if there's an associated bradycardia, but not specific for laryngospasm.
Okay, no, that's fine.
30 seconds.
So Elise, you've got IV access, he's deep on sevoflurane and breathing. You intubated him with the south-facing ray, and you tell the surgeon the boy's ready. So they've commenced an operation, and you notice that the capnograph is a flat line. What do you do?
Sure. So I would be announcing that to the room that we don't have an end tidal and it's a flat line, and I would be telling the surgeon to stop and potentially calling for help, particularly if the situation is not resolved quickly and it takes a while to get help. I would also have my anaesthetic crisis manual open as a cognitive aid as well to decrease my cognitive load. The causes of this could be an airway malposition, particularly if the tonsil gag has been put in and is obstructing the tube. It could be due to secretions in the tube, so I would suction the tube. I would get the surgeon to release the gag and see if that improves the waveform. I would also look at the patient, make sure the patient's colour is good, and scan the rest of the monitor and make sure heart rate, saturations, respiratory rate, and adequate. If it wasn't, and we were going down the line of heading towards an arrest, I would move to an ALS algorithm, or thinking about things like anaphylaxis causing bronchospasm.
I'll stop you there.
Or laryngospasm, and I'd also check the sampling line and circuit disconnect. So there's anaesthetic, patient, surgical factors.
Yep. Great. I'll let you go on because you're doing so well there, but great. Thank you. Okay. Neil, first question, please.
Okay, would you insist on a regional anaesthesia?
Okay, so just being aware that one of the contraindications for a spinal is patient refusal, ultimately. However, I would start by exploring for this patient what happened last time and listening with empathy to her story and not trying to interrupt her or give her a counter argument or correct her if I felt that what she was saying was incorrect. Allow her to voice her concerns and essentially try and work out exactly what were the worst parts of the birth trauma for her, because it may or may not have anything to do with the actual having a regional block. I would also get the records of what happened and see if I could also get a better story of what happened. And some women find that very healing to be able to debrief, even if I wasn't there, to be able to have a look at the records. Potentially that's enough. There is a lot of fear about a spinal. It's a bit of a misnomer. So I would be explaining exactly what a spinal is and the idea that the spinal cord's actually ended where we would normally go, explain that an elective Caesar is quite different to potentially having an emergency labour or Caesar. I'm not exactly sure what she had last time. And also discuss with her if she did proceed to a GA Caesar, the potential risks of GA Caesar, and check that she has informed consent. So that would be the idea that she wouldn't be awake to see the baby, that there is difficult airway, problems with difficult airway and aspiration risk, that the pain relief can be, she's likely to have more pain compared to a spinal. So I would, it may take more than...
Whilst not trying to scare her into having one thing or the other.
Whilst not trying, yeah. And I guess I'm a GP obstetrician as well, and usually I have quite good rapport with my patients, and I think trust and rapport, and maybe also getting her usual her obstetric doctor as well as part of the conversation is all part of the process.
That's very good.
Yeah.
You mentioned that it was an absolute contraindication. Can you just briefly give me some of the other contraindications to a regional anaesthetic?
Yeah, so local sepsis, severe thrombocytopenia, everyone's got a different number, it's like 75 to 100 for a GPA like me. Coagulopathy, whether they've been on recent anticoagulation or they've got coagulopathy due to some other reason, like severe preeclampsia, local sepsis.
That's good. You, despite your empathy and very caring approach, she's insistent on having a GA. How do you prepare a GA for the elective caesarean?
So part of my preparation would have started, hopefully we're at pre-admission clinic, but we may not be. I would do a standard preoperative assessment and an airway assessment of her, knowing that being pregnant in itself is already a potential difficult airway. I would prep my team and make sure I have the most experienced airway nurse, and we would do a team huddle to check that we've got the machines working well, we've got all the equipment needed, we've got suction. We might consider even doing RSI, cricoid pressure, even if she's fasted, if she's a high risk of aspiration. And we would give her some pre-medication for aspiration risk if she had significant reflux. I would make sure I've got 2 wide ball IVC cannulas and that there's fluids running and that they're 100% reliable. I would have my airway equipment, including the difficult airway trolley around. My first choice of airway equipment would be a video laryngoscope with a size 4 blade, unless I felt she had a really difficult airway. I might consider using the D blade. A bougie and a size 7 tube. Backup equipment would include other ETTs of different sizes, a backup LMA of different types and different sizes. I would have the sucker under the pillow and my adjuncts in terms of oral pharyngeal and nasopharyngeal airways, and direct laryngoscopes in case my video laryngoscope failed. I would also have my drugs drawn up. So for induction, I would use, assuming she doesn't have any allergies or a history of anaphylaxis, so to ROC, or a really strong history of anaphylaxis to anything, I would use 200 milligrams of propofol and 1.2 milligrams per kilo of rocuronium. That's my choice because rocuronium gives more prolonged paralysis than SUTS should my first attempt be unsuccessful, and I'm more familiar with using ROC than SUTS. I would then make sure she has very good pre-oxygenation for at least 3 minutes because she's likely to desaturate, position her in a good ramped position, do the induction, the intubation with my backup plans if it was unsuccessful. I potentially could have cricoid pressure if I thought she was high risk. And then after I secured the tube, I'd make sure the obstetric team was ready, prepped and draped, ready to go. And we would time it that as soon as the tube is secure, that there would be a rapid surgical time from skin to delivering the baby. After the baby is out, I would give analgesia, a long-acting analgesic. I could give boluses of fentanyl.
Okay. Moving on, you briefed your team and got ready, and when you assessed her airway, there was nothing to indicate a problem. You then find you can't hand ventilate effectively. What do you do next?
Okay, so I just wanted to clarify, did I try to intubate her or I just looked? Or...
Yeah, you've essentially now encountered a very difficult view that you didn't predict, and you're unable to pass the tube.
Okay.
And then you go back to bagging and using the hand ventilator, and you find it's very difficult to ventilate her effectively.
I've had one attempt at intubation unsuccessfully with a direct, and then now I can't hand ventilate. So we're in a potential issue of can't intubate, can't oxygenate. I would be declaring this crisis and calling for help and getting a cognitive aid and getting the difficult airway trolley. At this point, I would, if I can't hand ventilate effectively, I would check my positioning and see if I could ramp up this patient, use a vice grip two-handed technique, and use an oropharyngeal airway and check that the patient's deep enough and that I've actually given the muscle relaxant, that it's not, that I haven't inadvertently not given it. And then I would try again to hand ventilate and look at my monitoring to make sure that her saturations are okay. If that was not successful, I would...
you off now. Thank you for that answer.
I'd get the video laryngoscope, change blades, get an LMA in, change my lifelines, get the front of neck access, ready, set, go.
So, Alice, I know the question is it's a bit vague, but I'm going to ask you. You've seen this lady. You're seeing this lady. You've been asked to help out by your GP in urgent care. How do you go about caring for this patient, or tell me what is going through your mind, or as seeing this patient?
Right. So I'd like to get more of a handover from the GP and see what workup they've already done. And it just says they're asking for my expert assistance. So I'd be actually asking, what are you actually wanting me to do? Intubate this woman versus something else. So I would get more of a handover using my ISBA approach. This patient is really high risk. It sounds like she's potentially septic and in respiratory failure. Part of my discussions, if I was being asked to essentially intubate and ventilate this patient, would be to get a baseline of where she's at, her quality of life. It does say she's not got an advanced care directive. However, if she had capacity to consent, I would seriously be having a discussion with her about what the goals of care should be and whether or not it's appropriate to be intubating her, doing CPR. So that's my first one of the considerations, and whether or not, is palliation locally actually an appropriate option? It could be. The next step is I would also check that we have optimized resuscitation hemodynamics and treating her underlying cause. It sounds like she might have an infective exacerbation of her COPD. So I'd want to know that she's been optimally worked up in terms of having her bloods done. She's got IV antibiotics. She's got good IV access, and she's had appropriate boluses of fluids. Basically that she's had a sepsis management appropriately done, and also that other differentials have been excluded, so that things like pulmonary embolism, AMI, that we haven't electrolyte disturbances. I'd like to know, if I could get some previous information about what her baseline saturations are, a gas, and to see what that is. And if she normally sits at around 90%, maybe 86 is not that different. So it's quite contextual, I think, this question. That's what I'd start doing before I went, and I'd see if she's been on any non-invasive ventilation, whether or not she's had her COPD optimized with steroids, ipratropium. Yeah, I would do that before, we proceeded to doing anything more invasive like intubation.
Yeah, so I know the STEM doesn't give you whether she's on oxygen or no oxygen, but given the fact that she's normally on home oxygen, but we also, so like you said, you would get a little bit more information because we don't really know whether there's a CO2 retainer, whether she likes a hypoxic drive. So, so you've done that. The husband is telling you that there is their youngest child is getting married in 2 months' time. And she would,
okay. Yep.
In 2 months, in December.
Okay.
And the lady would be, if her physiological and her pathological situation allows her, she would like to be alive and around to witness that wedding.
Okay. So again, this would be an ongoing discussion rather than a yes and no. She will have to be shipped out, transferred out. So I could always speak to retrieval or the other hospital to see what they think and have a second opinion. And they also have to be happy to accept the patient and retrieve the patient. So in that way, it's good to share the load. And if we did decide that, yes, we are going to, if she's failed non-invasive ventilation and then we are moving to intubation and ventilation, then yes, as long as the patient and the husband are aware of the risks, we would proceed. Yes.
What will your difficulty be in ventilating somebody who is got acute severe asthma?
There's going to be a lot of issues with ventilating a patient like this. And also she's septic and could be shocked. She's also going to drop her hemodynamics on induction as well. So my strategy for all this, if we did go down this route, would be to try and keep her in the position that she's in that tripod posture, and pre-oxygenate her as well as we could. And again, it's about having good preparation, good equipment, your drugs and your rescue drugs ready. Where's the best place to do this? I think I would do this in theatre because I'm much more familiar with my ventilator and how to adjust my settings rather than in ED. And yes, so my plan would be to have this patient well pre-oxygenated sitting up, put an art line in, and have my induction drugs. I would use ketamine, a very low dose, 0.5 milligrams per kilo, rocuronium 1.2 milligrams per kilo, do an RSI and have a metaraminol infusion going, have and intubate this patient. And post-intubation, I would have her on a setting on the ventilator where I could minimise her plateau pressures, and I might need to increase her I/E ratio to 1:3, 1:4 to prevent and try and avoid gas trapping. So I might need to decrease her respiratory rate, tidal volumes, and allow some permissive hypercapnia, and also maybe at times disconnect the circuit to allow CO2 to escape. I'd be checking her blood gases regularly and monitoring for pneumothorax or other complications. And and checking her pressures, her airway pressures. It should be very difficult to ventilate. So I think I would also call for help with my second GPA.
Great. I'm going to call quits there. Sorry, Santhi. The time's up on that one. Okay, Neil.
Okay, at least you've read the preamble there. You've got a sudden readout on the screen. What would you do?
Yes, so we've got an issue of bleeding to deal with, and now we're going to convert to an open. So I would be declaring this emergency and calling for help, getting my visual aids to help decrease my cognitive aid. I would, using an ABC approach, review the patient as I'm communicating with the gynecologist about our plan. I would generally do a tube, an RSI tube for this. I would have done an RSI tube for this patient. I wouldn't have used an LMA. I would check that the tube is patent, that my ventilatory settings are stable, and the rest of my monitors, my hemodynamics are all stable, and go over my monitor again. I'd increase the FiO2 to 100%, consider it. I would check my access and make sure that I've got a second IVC, a large 14 to 16 gauge, and be running crystalloid fluids sat through with a rapid infuser, warmed fluids. I'd also be checking I'd put an outline in and start checking my HB. And if there was, I'd be communicating with the surgeon about how bad this active bleeding is, and if it's anticipated there's more, I would have a low threshold to declare a MTP and be on the phone to get blood products. I would potentially call a second GPA because there's quite a few tasks to be doing at this point.
You mentioned keeping the patient warm and giving warmed fluids. That's part of a triad. Do you remember any of the other components of the triad? The lethal triad?
We'll keep her warm. I would check her bloods and make sure her calcium is okay. Not sure, make sure that she's got good access and that she's keeping up with her blood products, put an IDC in and make sure her urine output is okay. I could switch to TIVA. I don't know at 8 weeks whether or not uterine relaxation with SIVO is an issue. Check her coags, make sure she's not getting a DIC.
Any other drugs you might use in somebody who's bleeding?
So tranexamic acid, I would use 1 gram, and I could start an infusion 1 gram over 8 hours. I'm not sure about the role of uterotonics at 8 weeks, such as oxytocin and ergot. I think it probably isn't harmful if she's not hypertensive, but it just may not work. And I would be liaising with the gynecologist about what surgical strategies they're doing to control the bleeding, and maybe they might need to move towards a hysterectomy. Okay.
After a coordinated team effort, they control the bleeding. She's has a tube removed, and she's managed on the ward post-operatively. What are your options here for both intraoperative and post-operative analgesia?
Okay, so intraoperatively, converting to an open is associated with more pain. I would be using combination of make sure she's had regular simple analgesia. She might have had a pre-med of paracetamol, and I would make sure in 4 hours she had another lot. If there was no contraindications for anti-inflammatory with bleeding, you may or may not want to give it intraoperatively. I'd also give her some clonidine, so she could have non-opioid opioid-sparing analgesia as well as opioids. So she's a chronic pain patient. I could give her some clonidine, 0.5 mics per kilo. The gynecologists where I work often like to give intraperitoneal ropivacaine local, and they think that works really well. So we would give that. You could also do a tap block as long as you don't exceed your maximal doses. And she would need some opioids intraoperatively, fentanyl. She could also have a ketamine lignocaine. She could have ketamine, lignocaine, magnesium as well. Post-operatively, again, checking that she's on regular simple analgesia if there were no contraindications. She might end up on a PCA or ketamine infusion. She would have, I think it would be reasonable to give her some long-acting opioids, given her chronic pain. And she would also have some immediate release oxycodone and or plus or minus tapentadol as well. And she could also have some oral clonidine. I think part of it is regular review of her as well. That is also part of the pain relief, is making sure that she feels looked after, cared for, and that we are doing our best to keep her comfortable.
You mentioned a tap block. How would you perform a tap block?
Yes, so I would use 0.2% ropivacaine, and I'd use 20 mils on both sides. Both sides. I would use an ultrasound guided technique and prep the area with some Chlorhex, and using an aseptic technique, I would look at the different planes, looking at external oblique, internal oblique, transverse abdominis, and that's where my plane would be to go with my needle. I'd be making sure
Which
that
plane would you go in? Sorry,
I would try and go through the transverse abdominis plane.
Yep.
I would make sure I can visualize the tip of my needle as I'm going through and feeling the pops, and I would be injecting, aspirating to make sure I'm not in I'm not going into a blood vessel, and then injecting my local anesthetic, and looking for that hydrodilation of where I'm trying to, where the plane is. I should be seeing the hydrodilation nicely.
Okay. You mentioned ketamine for analgesia. What dosage would you be using?
So there's different protocols. You can give a bolus of anywhere from 0.25 to 0.5 milligrams per kilo interop. That can help to prevent pain. However, there is the risk of dysphoria, so usually people give it early to prevent that from happening. If she needed a ketamine infusion post-op, there are protocols, and I think I'd have to look it up. I think it's like 4 milligrams per kilo, 1 milligram per kilo per hour, maybe, and then you can increase the infusion rate as needed. So,
Right.
Yeah.
Thank you very much. That is the hour up and all 6 questions done.